Thank you very much for your introduction. My name is Peter Kromka and I'm a trainee at the University Hospital of Bratislava in Slovakia. As you already figure out from the title, it's always lupus, I'm sorry. So, a middle-aged man, Caucasian male, engaged in long-distance running, was admitted to our hospital with approximately 8-month-long history of non-specific and highly fluctuating symptoms, mainly arthralgia and fatigue. In addition, he also recalled recurrent episodes of lower extremity rash on his legs, yes, and actually this preceded all other symptoms by several months. He was previously healthy. His family history was remarkable for his son's diagnosis of juvenile idiopathic arthritis, and he had also multiple exposure to tick bites in the recent past, so he was referred to infectious disease specialist for further assessment. However, no definite cause could be reached. Luckily, the patient provided us with some interesting photos of his skin rash, which was highly stereotypic in nature. It invariably occurred after exertion. It typically spared the skin below the sock line. It was mildly itchy, and there was complete and spontaneous resolution within a few days. On admission, the patient appeared unwell. However, his vitals were normal except for fever. His X-ray was also normal. Initial labs showed mildly increased inflammatory activity and low complement levels. All other laboratory investigations were normal. So, an extensive workup failed to identify infectious, hematological, or neoplastic condition. All imaging studies were unrevealing, so a CT scan was done, which identified discrete bilateral pleural effusion. Autobody testing yielded positive results for anti-nuclear and anti-double-stranded DNA antibodies in conjunction with other clinical and laboratory findings. A diagnosis of SLE was made, and the patient received treatment of prednisone and hydroxychloroquine immediately. However, during the first week of admission, the patient declined clinically. He complained of chest pain and palpitations. His ECG showed atrial flutter, which was successfully managed by propafenone. Echocardiography was remarkable for LV dilatation, and there was also a small pericardial effusion. In order to further assess disease activity and possibly concurrent organ lesions, a PET CT scan was done, and there was increased tracer uptake in the myocardium and ascending aorta. This was indicative of major organ involvement, so a pulse steroid therapy was commenced immediately, consisting of 3 pulses of methylprednisolone on 3 consecutive days. This approach led to marked laboratory and clinical improvement, and patient was discharged after a few days without any symptoms. We presumed skin involvement in our patient was consistent with diagnosis of exercise-induced vasculitis, which is not uncommon. However, it's certainly underreported and underestimated condition. Generally, it's considered benign and self-limiting. As I mentioned, it has a typical clinical picture. Data in the literature are scarce. I was able to find only one case report of exercise-induced vasculitis linked to ACLA. So our patient was able to return to his previous activity level within 6 months of diagnosis, and there was no recurrence of this condition over the current follow-up period. So this observation suggests it might be related to disease itself. And to conclude, is well-known diagnosis of SLE is often delayed, especially males and older adults are at risk of adverse outcomes. Men possess a higher risk of developing certain phenotypes, such as cirrhosis, nephritis, or cardiovascular involvement. Subtle skin or joint involvement may remain unnoticed for a long time, and by the time of diagnosis, a life-threatening condition can be present, as it is in our case. Exercise-induced vasculitis has a typical clinical pictures, and its recognition is highly relevant to physicians for 2 reasons. Firstly, to provide reassurance to the patient and avoid unnecessary treatment, because this is pretty benign condition. However, there are clinical scenarios. For example, when you have a positive family history or there are clinical data suggestive of something more serious, physician should proceed with the caution, and maybe our threshold for further investigation should be lowered in this case. Thank you very much for your attention.
Thank you. Maybe one question to you and to Dr. Legault. Was it lupus? Was it lupus, which is quite not reassuring diagnosis, or was it exercise-induced vasculitis, which is not that scary? Which one was it?
It was exercise-induced vasculitis associated probably with.
But the lupus didn't have other manifestations here.
In him?
Yes.
Lupus had manifestations. Lupus perimyopericarditis.
In him?
Yes.
Maybe
yes.
I missed it. Kim?
Yeah, thank you, Dr. Kromka, for your talk. It's great. The other thing I was interested in is, so a lot of the cutaneous vasculitis, especially that which is indolent, positional, is actually seen in Sjogren's. So very, very frequently when we label patients with lupus, we are actually sometimes glossing over their concurrent overlap autoimmune diseases. Did he have any features of Sjogren's, serologically or clinically?
No, there were no features of Sjogren's, and for example, his rheumatoid factor was negative, and there were no features, for example, rheumatoid arthritis, and so we didn't do tests for Zika syndrome because there was no clinical clues to this diagnosis.
And he had no SSA or SSB antibodies?
Excuse me?
He had no SSA or anti-Ro antibodies?
It was negative.
The other question that I had was the ascending aorta involvement on the PET CT. Was that in keeping with what we don't do a lot of PET CTs in Hamilton. I'm not sure the access in other places, but is that a common etiology, or is that a common concurrent thing seen with myocarditis? Because I would just think about the consideration of other types of vasculitis as well with evidence of aortitis.
Usually MRI will be better. However, when you presume there is some autoimmunity condition or systemic inflammation, in this scenario, PET CT scan can be useful. Further detect some inflammation.
You have a question up there, if you can pass to.
Thanks. Very nice. Again, a great presentation. I know the diagnosis was made, but when you first mentioned tics, and then I thought about Lyme Borrelia, was that tested for Lyme myocarditis also in the differential diagnosis in Borrelia?
Yeah, and it was all negative.
Well, thank you very much. I have to reverse my previous suggestion that you remove the titles. I got so concentrated on his skin and exercise but I forgot that myopericarditis was the first word in your title. So let's keep it there. Thank you very much. Next.
Thanks.